Okay, well, good morning everyone. Thank you all for being here today. As you all know, I'm Lauren and I've been the CRASH-3 trial manager, and Ian and I are absolutely honoured to be here today with you all. So thank you all for making the journey. Everybody around the world has made CRASH-3 what it is today. So I just wanted to say a very heartfelt thank you to each and every one of you, to all of your teams that also can't be here today, and to all of the collaborators around the world. From myself and Ian, Halima, and all of the team back at the Clinical Trials Unit, thank you all so much. So without further ado, I shall now hand over to Ian for the CRASH-3 trial results.
Okay, so first slide. So next one. Right, so this is a man, he's had a head injury. Inside his brain, he's starting to bleed. Next slide. So that was his CT scan on hospital admission, and that was his CT scan 12 hours later. So patients with head injuries often get intracranial hemorrhage, and it carries on after hospital admission. So the objective of the CRASH-3 trial is, can we stop that from turning into that? Or there'll be some patients who don't have a bleed at all, and can we stop them having an intracranial bleed? Next slide, please. Now, this is the data that we had from the CRASH-2 trial before we started the CRASH-3 trial. So I just want to first of all make sure that everybody's familiar with this way of showing trial results, right? So first of all, the effect of a trial treatment is expressed as something called the relative risk, right? The relative risk. Now that's the risk, in this case, of dying in the treated group divided by the risk of dying in the placebo group, yeah? So it's the risk of dying is just the number of deaths divided by the number of people in the treated group. The risk of dying in the placebo group is the number of deaths divided by the number of people in the placebo group, right? So we express trial results as a ratio. We express the effect of a treatment as a ratio of the risk of death in the treated and the untreated group, right? Now, if the ratio is 1, that means the risk of death in the treated group is the same as the risk of death in the placebo group, and there's no effect of the treatment. If the risk is less than 1, it means the treatment is good. If the risk is more than 1, it means the treatment is bad, or it means there's the higher risk of whatever that thing is in the placebo group. Right. So, the relative risk. Then, so this is something that we see a lot. You see a box and you see some lines. So the box is located where, at the point of the relative risk, right? The box tells you, the location of the box on this axis tells you where the relative risk is. So this box over here, well actually it's off the scale, so it's about 0.6 something, maybe 0.68 or something like that. So that box there tells you where the relative risk is. And then these black lines are a confidence interval. Now that gives you a sense of, whenever we measure something, there's always some impact of the play of chance, right? What we really want to do is measure, we want to measure the true value in all of the world, you know, in all of time. But we just do, even though our trials are really big, they're just a sample of the all of time, right? So what we have is, we have a sample, and that sample has some variability. And it's just the impact of the play of chance. You know, we could have got a very extreme result by chance, we could have got a less extreme result. So this is the confidence interval, and it gives you a sense of the impact of the play of chance on the results. Now the most likely result, of course, is is where the box is. The least likely results are the very ends of the confidence intervals, but it's more probable that the result is around, the midpoint, around where the box is, right? Now let's see, what else do we notice? Okay, so we've got box, we've got confidence intervals, then we've got this diamond here, right? Now this diamond is the result of, is the overall result, right? So these are actually subgroups. They're subgroups by time to treatment, right? So this diamond here is the overall result. The point estimate is here. So in this case it's 0.85, and we've got a confidence interval goes from 0.76 to 0.96, and then we've got a p-value here. Now the p-values are the most misunderstood measure in the whole of medicine, and it's a very difficult concept. But it starts off, behind every p-value there's something called a null hypothesis, yeah? And the null hypothesis is that the treatment doesn't have any benefit, right? That the risk in the treated group is really the same as the risk in the untreated group. So that's the null hypothesis. And then this p-value here is based on, it goes like this: if the null hypothesis is true, what's the chance that we would have got a result of 0.85 just by chance, right? So that's how the p-value works. If the null hypothesis is true, that the treatment is useless, what's the likelihood, or what's the chance that we would have got a result of 0.85 by chance alone? And the probability is 0.007. So that's 7 in 1,000, isn't it? So it's very unlikely, yeah? I mean, it's not impossible, but it's very unlikely. 7 in 1,000 is very unlikely. So we've got these things then. We've got point estimates, where the boxes or where the diamonds are. We've got confidence intervals, and we've got p-values. So, there's one more thing. The boxes, and I don't know if you can see it here, but the boxes are not all quite the same size, right? So some boxes are slightly bigger than other boxes. So why are the boxes a different size? Well, the boxes are of slightly different size because they are proportional to how much information is in the estimate. So an estimate with a big confidence interval, with very wide, these lines go way over there and way over there. An estimate with a big confidence interval has a small box because there's not much information in that estimate. An estimate with a very narrow confidence interval has a bigger box. Yeah? So the boxes are proportional to how much information there is in the estimate. So this is the information that we had before we did the CRASH-3 trial, and it shows that early treatment is good, and late treatment is not very good at all, and could even be harmful. Okay, go over the next slide. So tranexamic acid went into routine medical practice after the CRASH-2 trial, and this is some doctors in Peru using tranexamic acid on a patient. This is the first patient they treated with tranexamic acid based on the results of the CRASH-2 trial. But head injuries was always an exception, right? So tranexamic acid went into the guidelines in the UK, but not isolated traumatic brain injury. So isolated traumatic brain injury was an exception. And the question was, well, does it need to be an exception? Next slide. So we looked at the evidence that there was for the effect of tranexamic acid in head injury before the CRASH-3 trial. And during the CRASH-2 trial, we'd done a very small study in a few centres. And there was a guy, Surakrant, in Thailand. he did a small randomised trial of tranexamic acid, and they both got kind of favourable results. This is the effect on mortality, but you can see, look, the boxes are really small, and the confidence intervals are really wide. When you add them up together, actually you do get evidence of benefit. Really, it's not very good evidence of benefit. I mean, the confidence intervals. The confidence intervals are very wide. It's officially statistically significant at 0.05, whatever that means. We'll talk about that in a minute. But it did seem to favour tranexamic acid. But it's not really reliable. You can't really trust these small trials. Next slide. So that's why we did the CRASH-3 trial. And the eligibility criteria were adults with traumatic brain injury. Well, you know all of this. Initially it was within 8 hours, then we changed it to within 3 hours. Next slide. And then you can see where we changed the recruitment from 3 hours, from 8 hours to 3 hours. When you're doing a trial, it's like, it's like a heavy thing that you're trying to take off, and so you go down the runway and you try and go up. And so we'd gone down the runway, and then we started to take off, and then we changed the protocol, so we started to lose altitude. So we started to lose altitude, and there were sometimes I think we thought we were going to crash, but we managed to get up to the target. We didn't quite make it to the target of 13,000 patients. Actually, we ran out of drugs. No. So the drugs expired. We had a certain amount of drug that we could purchase for the trial, and the batches were getting close to their expiry date. And of course, especially with the regulator in the room, you cannot continue after the batch has expired. So the day before the batch was going to expire, we said, recruit up until midnight, but then stop, or the regulator will be here after us. So we did, and we ended up with, well, next slide. I think that's where we changed the protocol, and next slide. So this is trial recruitment by country. Lauren has already... so the biggest recruiter was Pakistan. Pakistan is a big populous country. There's lots of people there. We've got fantastic collaborators there like we have here. But they have these huge hospitals where it's like every morning there are just maybe 100 patients, with head injuries, hundreds of patients, huge hospitals with lots of patients. The UK did very well. We had lots of hospitals in the UK recruiting patients, and then Malaysia was the third highest recruiter. And then we have a long tail of hospitals that recruited fewer patients, but still it all made a contribution. So that's the recruitment. Next slide. So we're getting close. Getting close. So this picture you see in every clinical trial publication, and it's called a consort flow diagram, right? So there's something called the consort, right? With clinical trials, this word consort you hear, and it's a sort of guideline for how randomized trials should be reported. And they have a sort of consort checklist of all of the things that you should report in your manuscript. So when we made the manuscript for the CRASH-3 trial, we wrote the manuscript, and then we looked down the consort checklist. Have we given that? Have we written about how we blinding and placebo control and allocation, all of that? So this is part of the consort, and it's consort flow diagram. It tells you how the patients, So we had 12,737 patients, 6,500 allocated to tranexamic acid, 6,400, 6,300 allocated. And the difference is just chance. The difference is just chance, you know, a few more by chance, a few less by chance. Very good, everybody got baseline data, and this is good news. We had very little consent withdrawal, you know, very little people withdrew consent, and very little loss to follow-up. So we ended up with knowing about 99% of the patients included in the trial. Now that's very important, because once the big idea of randomization is that you randomize patients into two groups, they're identical apart from the treatment. Yeah? You get two groups that are almost identical apart from the treatment. Any slight difference, chance, but there won't be even slight differences. So you've got to make sure you follow all of those people, otherwise you lose the power of randomization if you lose them along the way. So once you've got two groups that are made by random allocation, you need to follow them up. So we don't allow people not to have complete data. If we think there's going to be a problem with the data, you know, forms aren't coming back, that's it. We can't, you know, we have to say goodbye. But the quality of the data in Malaysia was outstanding, and the quality of the data in all our participating centres was outstanding, and now we've got 99% follow-up data. Okay, next one. So, the big idea with randomization is if chance and chance alone is the only thing that determines who goes into the two groups, doctor can't influence it at all, you get two groups that are the same apart from the treatment. And then after the consort diagram, the next thing you see in a clinical trial paper is a table of baseline comparison. Yeah? Now, I'm not going to show all of the baseline comparison tables because it would take too long, but they are beautiful, right? They make me want to cry because it's so wonderful. Randomization is just a miracle, you know? It's just so beautiful. You know? I get very emotional about randomization. But look at this. Glasgow Coma Scale, treat Tranexamic Acid group, placebo group, 38%, 38%, 33%, 33%, 28%, 20. Look at that, you know, isn't that, you know, it's so special, isn't it? But, you know, everything's beautifully balanced, you know, just a fraction of a percentage difference. And the thing is, that's not the beautiful thing. The beautiful thing is that they're even balanced on things that we haven't thought about. How would you do that, you know? If I said to you, give me two groups that are identical on a factor, and I'm not going to tell you what the factor is, you couldn't do it. You couldn't do it, you know? If I said, give me two groups that have got the same proportion of males, you could do that, right? Two groups with the same average age, you could do that. But if I said, give me two groups that are identical on a factor, I'm not going to tell you what the factor is. It could be their favourite topping on a pizza is mushroom, you know? But that would be equally balanced in this. It's a miracle, right? That's why randomized data are so special. You know, that's why we spend so much time in our lives doing them, you know? The data from randomized trials are very special. They are like nothing else. Now this was interesting. This is interesting. So, lots of interesting things on here, right? So, first, very nice balance. But look, this was a surprise to us. 10% of the patients had bilateral unreactive pupils at baseline, right? So they haven't even been given the trial treatment yet. So doctors, quite a few doctors said to me, look, why are we randomizing these patients into the trial? Because, you know, they've got bilateral unreactive pupils. These patients are going to die. They're not going to be, they can't really benefit from tranexamic acid because you know, they've got a very poor prognosis. Whatever we do now. And we said, yeah, you're absolutely right. We did not intend to have 10% of our patients with bilateral fixed dilated pupils. In the protocol, we had something called the uncertainty principle, which is like, you should only put a patient in the trial if you're uncertain as to the balance of risks and benefits. Now, if a patient's going to die, whatever you do, they cannot benefit from the trial treatment. So we hoped those patients wouldn't be put in the trial. But partly our own fault, because we say, come on, recruit, do, you know, don't miss any patients. What we ended up with is quite a few patients with bilateral unreactive pupils. And then we started getting a bit worried about it. We thought, this could be a problem, because it would dilute the treatment effect if there is one. Yeah. So I'll talk about that in a minute. Next slide. So, more emotional baseline comparability. This is like even, well, first of all, we had quite a lot of patients with GCS-3 as well. They do very badly. That was a bit of a worry. So fixed dilated pupils, GCS-3, both of them do very badly. But look, beautiful. Individual Glasgow Coma Scale, beautifully balanced. Next slide. So this is how patients died, right? So patients die on the first day, you know? So there were, first of all, there's a lot of deaths in this study. There are 2,500 deaths, right? Now the information in a randomized trial, what makes these boxes, big or small, is not the number of patients in the trial. It's the number of events in the trial. The number of deaths is the information in the trial, right? And there were 2,500 of them. Now, most randomized trials in head injury don't have 2,500 patients, but this one has 2,500 deaths. So this is a trial that's full of information compared to other trials. And where did those deaths, when did those deaths occur? They occur mainly on the first day, right? So, you know, most patients with head injury die on the day they were admitted, within 24 hours of their injury. Okay, next slide. Well, there is any potential for interruption here, you know, just because I'm trying to explain everything. It doesn't mean, you know, you can ask me any question. At the back there, yeah.
Is it the number the same, more or less, between the 10% non-reactive people is now with the death within 1 hour? Is it correlated?
Yeah, that's a good question. I can answer that. I'll answer that in the next 2 slides. Yeah, but I've registered the question. I understand the question, I think. So you said, I think you're saying is this: if what I'm saying is true, that patients with bilateral unreactive pupils die whether or not they get the treatment, then in that group there should be no effect of the treatment. Yeah? And the numbers of deaths in those 2 groups will be the same. Yeah, I understand the question. So I'll come to that in a minute. It's a very good question, actually. Next slide. Oh, go back one. So with a clinical trial, you've got these things. You've got this protocol, right? The protocol is the recipe of how to do the study. There's another document that's quite important. It's called the Statistical Analysis Plan, right? And it's like a recipe for how you're going to analyze and present the results. And you do this because there are so many possible results that you could do. You know, you could say, well, what is the effect of tranexamic acid in, you know, I don't know, like people, you know, males between the ages of 35 and 45, you know, there's any number of possible results. But what there is, because you can analyze the data in lots of different ways, we could do this. We could analyze the data in lots of different ways, find results that we like, and then emphasize them. Yeah? And said, oh, we expected the treatment to be more effective in males between the age of, and actually it's just the play of chance, but once we've seen it, we've latched onto it and, claimed that it was our intention all along. So what we have to do is we have to write a statistical analysis plan saying what we're going to analyze and how we're going to analyze and what we expected. Yeah? So this was the statistical analysis plan, and the next slide. And this is the key thing, right? The thing that you put most weight on in the trial is the primary analysis, right? The primary outcome. So the primary outcome is head injury death in hospital within 28 days of injury among patients randomized within 3 hours. So, about a quarter of the way into the trial, we realized that it was unlikely that the treatment was going to be effective when we treat patients late. So we said the primary endpoint was going to be in patients treated within 3 hours of injury. And then because we got very concerned about these patients with bilateral fixed dilated pupils and patients with a GCS of 3, even before they'd been treated, we made this sensitivity analysis on the primary endpoint. We said, and we spelled out our concern in the analysis plan. We said, TBI patients who have a GCS 3 and those with bilateral unreactive pupils have a very poor prognosis. The inclusion in the CRASH-3 trial of such severely injured patients who have little potential to benefit from the trial treatment would bias the treatment effect towards the null, right? It would just dilute any treatment effect towards the null. We will therefore conduct a sensitivity analysis that excludes those patients, right? Yeah.
Just give an overview. What is a sensitivity analysis? What does it entail?
A sensitivity analysis is like, it's like you do it this way and you do it that way, really. It's like you see, you've got this assumption and you see if the results are sensitive to this assumption.
All right.
Yeah. Okay, I think the next result is the main result. I think so. I think so. All right, go on. Next slide. Yeah, it is. All right. So this is the main result, right? So let's have a look what's going on here, right? So this is the tranexamic acid group. This is the placebo group. These small n's here and here are the number of deaths. These are the number of patients in that group, and these are the percentage of deaths in the treated group and the placebo group. So in head injury patients who got tranexamic acid, there were 18.5% dead. And in the group that got placebo, there were 19.8% dead. What do you think of that? Well, it's not bad. It's not good. So there is less death in the tranexamic acid group, right? And the relative risk is on the right side, right? It's less than 1. But the confidence interval, the range of values that's compatible with the chance, it goes from, well, it could be quite a big benefit, could be 0.86, but it could be 1.02. So this is looking on the right side of it's on the good side, but we've got this, this confidence interval that says, well, it could be really good, or it could be no good at all, right? But when we got to the sensitivity analysis, things are looking a little bit better. Now we've got 12.5% dead in the tranexamic acid group and 14% dead in the placebo group. Now we've got a relative risk of 0.89. Now 0.89, what that means is, like, the risk of death in the tranexamic acid group is 0.89, what it was in the other group. Or you could say there's an 11% reduction in the risk of death. You know, it's like 1 minus that is 11. Yeah, 0.11, 11%. So there's an 11% reduction in the risk of death with tranexamic acid. It could be much bigger. It could be as big as a 20% reduction, yeah? Or there could be no reduction at all. So that's the main result. That's the primary endpoint. And any questions about that? What do you think about that? Is this good news or bad news? You're not sure. Nobody's sure if it's good news or bad news. What do you think? Over there at the back with your question. Do you think, are you happy or sad? She's not sure. Nobody's sure whether to be happy or sad, I don't think. Julina, are you happy or sad? Well,
11% is something.
11% is pretty good, isn't it?
Pretty good, which means that
Huh?
Up to 20% should be
Because-
reduced. Maybe up to 20%, 0.8.
Yeah.
Yeah.
So 0.89 is 11%, but it could be as much as 0.8. So it could be, you know, it could be really good. 20% reduction in the risk of head injury death is pretty good, isn't it?
Yeah.
But it could be, you know, we could have been really lucky and there could be no real benefit.
There is hope.
There is hope. I think it's more than hope. I think this is very encouraging, personally. What do you think at the back?
I think this is real good results.
You think it's a good result? Why do you think it's a good result?
Because you just mentioned that 11%. This is talking about that.
Yeah.
This is talking about that, and we exclude those which is S3 and both uneffective, where we know they will definitely die. So
Yeah.
what about those you say as of 4 or 5? So if we're talking about this is like an extreme one.
Yeah.
So the extreme also has some benefits already.
Yeah.
So we potentially see more benefits after this.
Yeah. So after you take, you know, there are overall there's a very slight benefit. Well, there's a benefit, but there's a lot of patients in here that had no potential for recovery because they were dead when they arrived in hospital, really. But if you take those out, patients who've got the potential for benefit, you know, they benefit from this treatment. So it's good, but it gets better. I think it gets better. The next slide. Because we pre-specified some subgroup analyses as well, right? Now, this is subgroup analysis by severity, right? And here we've got patients with mild and moderate head injury, and here we've got patients with severe head injury, right? Now, most patients in the world have mild and moderate head injury, right? There are about 70 million head injuries every year in the world, and 95% of them are mild and moderate, yeah? So even though you might remember the most severe head injuries, and look, because that's actually the ones we all pay attention to, you know, they're the ones that come in, they have a crash call, everybody's around them, intubating them, all that sort of stuff. That actually they're a minority of all the head injuries in the world. The most head injuries are mild and moderate. In this mild and moderate group, we get a very large treatment effect. Yeah? Quite a big treatment effect. Yeah, this is 0.78. My goodness, that's huge. Yeah? So a very big treatment effect in patients with mild and moderate head injury. And patients with severe head injury, not much going on. Yeah? Not much. not much evidence of benefit in severe head injury. Similarly, pupil reactivity. In patients with reactive pupils, you get quite a big benefit, but there's no evidence of benefit in patients with unreactive pupils. So, I mean, you know that the reason that the pupil dilates is because, I mean, often you've got something growing inside the head, either a hemorrhage or diffuse swelling, but, you know, this thing's inside, you know, this, maybe it's, you know, an extradural or a, you know, subdural hemorrhage, extradural hemorrhage growing inside the brain, pushing the brain down, the third nerve, you know, folds over that, you know, cliff, you know, that bony thing, and it gets pressed down. And so pupil dilation, unreactive pupils, tells us that actually the thing we're trying to prevent has already happened. Yeah? The thing that we're trying to prevent with tranexamic acid, because tranexamic acid reduces bleeding, in most cases has already happened. So in patients in whom it hasn't already happened, there's evidence of benefit. But in patients where it has happened, there's no treatment effect. So maybe the main result, you know, isn't where the action is. Maybe it's actually understanding how tranexamic acid works that we have to. Now this analysis includes patients with GCS3 and bilateral pupils. They're in there. Yeah? So there's no evidence of benefit in there, in those. But if they don't have those things, you know, mild and moderate head injury, there's quite a big treatment benefit. Next slide. So, like what we said, we also said we'd do some different analysis. We said we'll look at the impact of baseline severity on the treatment effect in a regression analysis. That's a little bit more complicated analysis. It's a you know, sort of you know, you have an equation, it's in the computer, you know, you fit a line to the data, and you have different terms. Difficult to explain a regression analysis in a few minutes, but in this one we found strong evidence that the treatment effect does vary by severity. So so basically when you look at mild, moderate versus severe, that's separating it into two. But if you look at the GCS as a continuous thing in a regression analysis, so you're looking at the GCS going 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, and then you fit a line to it, you get evidence that the treatment effect does vary by severity. And that's the p-value for heterogeneity. So in here, like I've told you before, every p-value has got something behind it called a null hypothesis. With a heterogeneity p-value, the null hypothesis is that the treatment doesn't vary by severity. You know, it's the same irrespective of severity. Well, now we've got a very low p-value again, so it's unlikely that you'd get such severe heterogeneity by chance alone. It's likely that there is real heterogeneity here. That actually the treatment effect is different depending on whether you have mild, moderate or severe head injury. Next slide. Now we also thought that time would be important. We thought that earlier you got the treatment, the better. And we got this, and sort of, I was expecting time to be much more important than this. So, you know, it does look like, you know, this is less than 1 hour, 1 to 3 hour, greater than 3 hours. It does look like you get a bigger treatment effect if you give the treatment early, but it's not a very clear, it's not a very strong pattern. And the reason is that time and severity are mixed up with each other, yeah? So actually, the patients who come to the hospital first are the severe ones. The patients who come to the hospital later are the mild and moderate ones. The severe ones come in by ambulance and they're attended to immediately, so they're randomized quickly. The mild and moderate ones, sometimes they come in with their relatives. They sit in the green zone, slumped over in a chair. They might wait there for a bit of time before anybody pays them any attention. So we recruited those later. So time and severity were really mixed up with each other. And so the severe patients, the ones in whom the treatment was less effective, seemed to come first, and the mild and moderate patients, the ones in which the treatment looked to be more effective, came later. So time and severity are mixed up with each other, so we've got to try and separate them. So next slide. So we looked at the effect of time separately, right? So these are mild and moderate, and these are severe. Now, in severe patients, this is the relative risk here. It's slightly on a different axis this time. So this is the relative risk. Low down here means the treatment is beneficial. Up here is the treatment's harmful. This line is the overall effect of the treatments, like the box, and this is the confidence interval. But in severe patients, there wasn't much evidence of a treatment effect, and so if there's no treatment effect, then time doesn't matter. If the treatment doesn't work, then it doesn't matter when it doesn't work. It just doesn't work. It doesn't work early, doesn't work late, doesn't work at all. Not particularly effective for those patients. But in patients with mild and moderate head injury, earlier treatment was much more effective, right? So in the patients with mild and moderate head injury, time was really important, that actually, if you give the treatment really soon, there's a huge, huge benefit. And it decreases as time goes on until about 3 or 4 hours. 240 minutes. 4 hours. 4 hours, there's nothing much going on. But in the first 3 hours, there's quite a lot of benefit. But time is really important. And that's a very interesting result. But it makes biological sense, doesn't it? What we're trying to do is prevent bleeding in the head. The severe patients, when they arrive in hospital, they've already got lots of bleeding in the head. So we can't prevent it because it's already happened. The mild patients are bleeding more slowly. They have less blood in their head when they arrive in hospital, but the sooner we treat them, the better, because we're preventing bleeding into their head. Okay, next slide. So, what I've shown so far is the primary endpoint, which is head injury death. I've shown you the subgroups that are all on the primary outcome. This is the results of the CRASH-3 trial in the context of other trials in head injury. So before we did the CRASH-3 trial, we just had this one. Then this is our trial here. It's got a big box here because there's lots and lots of information in it. The confidence intervals, quite narrow. There was another trial of exactly the same treatment that we used. Tranexamic acid, 2 grams, at the University of Washington, and it got almost identical results to ours. So this is our result and their result added together here, and we get this. We've still got a 0.89. The confidence interval is getting a bit narrower, 0.8 to 0.99. We didn't add these to this because I find small trials overestimate treatment effects, and I think we could have made our treatment effect a bit bigger by adding these trials, but I don't think that would be the right thing to do, because I think this is not very trustworthy. But this is quite trustworthy. So I think this is a very good news, you know, that tranexamic acid reduces head injury death. Reduces death in patients with head injuries. They're both within 3 hours, these studies. So this is a very good news. This is the first drug ever shown to improve outcome in patients with head injury. There is nothing.
Yeah. Can we say tranexamic acid reduces head injury death in the mild and moderate head injury?
Definitely we can say that.
Because
This is saying
the bottom line, that's it, right?
yeah. This result is for all head injuries, right? So this isn't broken down by severity. This includes patients with severe head injury. So if you looked at this result and you say, what does that show? Tranexamic acid reduces head injury deaths. So tranexamic acid reduces head injury deaths, but it's particularly effective in patients with mild and moderate head injury, where they've got more potential to benefit. Right, I'm going to take my glasses off. Any questions? You must ask questions. Go on, go ahead.
I think if we look to A to B, meaning the only sole management head injury is tranexamic acid, 11% is nothing. But we're looking at the thousands of management in terms of oxygenation, ventilation, hospital surgery, definitive surgery, and tranexamic acid is actually one component of actually reducing the risk of bleeding. 11% I think is very significant. In fact, if you look back into your severe head injury just now, even though you say it's insignificant, for me it's reduction in small percentage of patient. This we're talking about two subtype of patient with a prognosis which is probably high mortality, low mortality. We're talking about those with high mortality, low prognosis, but with a certain amount of percentage compared to one mild moderate. I think it's significant. You understand? So I think most of us think 11% is nothing, but we're actually looking at one parameters of the treatment and one management.
Yeah.
So I think.
Yeah, I've always felt 11% is quite.
Yes.
I've always felt that's quite good. You know, it's like. You know, for head injury, you know, where everything, where all of the damage, a lot of the damage happens at the time of the injury. You know, the brain is torn and so you've only got so much potential to reduce. But the thing is that if you say that there's 70 million patients with head injuries, you know, an 11% reduction across all of those patients, that's a lot of death. We're trying to work this out in the office now. We're trying to estimate how many lives tranexamic acid could save if only patients in hospital received it. And it looks, it's tens of thousands every year. Tens of thousands, possibly hundreds of thousands, but you could be very safely say tens of thousands.
If you think in Malaysia, 85% of trauma is head injury. Whether get the neurosurgeon, 85%. The main injuries that they'll get is head injury, right? So if we can do something, the small group of patients who not ours is not too small, right? As Adi says, 11% is right. Hopefully somebody can become a doctor from that group.
More questions? Did you have more questions? I'm picking on you now because you had a question to start with. Ah, yeah, go.
I just would like to ask under the group of severe head injury, because personally I think I wanted to translate this into clinical practice. I think that's more important when you have the results of the trial. Because when we look, the GCS3, that's pretty straightforward. But we the practice was considered is GCS. And when we look at where we practice now, those that GCS less than 5 usually will not be proceeded into such surgery. So I'm more interested looking those at 5 GCS, 5, 6 till 8. So what sorts of outcome that tranexamic will assist or contribute?
Yeah.
That, because you did the regression analysis just now,
Yeah.
based on the GCS. So I was of the assumption that the highest of GCS, meaning that the more benefits.
That's right. What I've presented today is only the analyses that we've pre-specified in the analysis plan. Now we've got the results. So the rules of publishing are that you have to stick to the analyses that you pre-specified for your main results paper. But how you use your results, how you interpret the results in clinical practice, you don't have to follow any rules. You know, you can just decide. You have to look at the whole picture and say, you know, and what you've just said, actually, the UK collaborators, because we had a meeting like this in London where all of the doctors from all of the UK came, and they said, well, we're going to give it to everybody. We'd give it to everybody as soon as possible. Because they said, we've got nothing to lose and everything to gain. And, you know, if patients with a GCS3 and fixed dilated pupils are going to die if they get tranexamic acid, it's not going to harm them, you know. Actually, I'll come on to, I haven't shown any results for disability and side effects, because that's an important consideration. But if there's more questions on, I'll go on to disability and side effects now, if you like. Yeah? Okay. So can I have the next one, slide? So non-head injury death. Now in this trial, head injury death was the primary endpoint, and there were nearly all of the deaths were head injury deaths. So head injury death was almost all-cause mortality, but we had a few deaths that were not from head injury, and these were things like, they were all sorts of a mixed bag of things. We had organophosphate poisoning, we had high cervical transection, we had adverse reactions to blood transfusions. Now they're not going to be affected by tranexamic acid, and they're just randomly varying. They weren't caused by tranexamic acid. That was just, you know, that's just random noise. You've got to choose what you think is affected. I'll explain this on this blackboard over here. Do I need to bring the blackboard over there? Like, actually. So like basically, you've got cause specific, and you've got all cause mortality, right? So say we've got this, right? Now, basically, in a randomized trial, the measure that I've said is of interest is the relative risk. It's the risk of death in the treated group divided by the risk in the placebo group. So the risk of death in the treated group divided by the risk of death in the placebo group. Now the risk of death in the placebo group is the number of deaths in the treated group divided by the number in the treated group, and then that's the number of deaths in the placebo group divided by the number in the placebo group. Now, as it happens, that the number in the treatment group and the number in the placebo group are usually about the same, right? So actually, how this works out is the relative risk is really a ratio of the number of deaths in the treated group to the number of deaths in the placebo group, right? It's very simple, yeah. So really, you know, you have to take into account denominators, but it simplifies quite a lot to the number of deaths in the treated group divided by the number of deaths in the placebo group. So once you realize that, then you can, I found this a bit of a breakthrough. Once you realize that, you can make up little imaginary trials in your head. And so imagine you have a trial and you randomize 10 people to tranexamic acid and 10 people to placebo. So this is the tranexamic acid group, and this is the placebo group. And we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 people in the tranexamic acid group. Ooh, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 in the placebo group, right? So we randomized trial, 10 in the placebo. And like, supposing you got 4 deaths due to head injury, 4 deaths or due to bleeding into the brain in the placebo group. And the placebo group is telling us what we would see in the treated group had we not treated them. Yeah? So we would have got 4 deaths too, but say the treatment reduces the risk of death. And so it stopped these people, you know, we got 2 less, right? So now, this is just a sort of thought experiment, right? So we've got 2 deaths due to bleeding into the brain in the tranexamic acid group, and 4 deaths due to bleeding in the brain in the placebo group. So the relative risk is 2 over 4, which is 0.5. Oh, that's not very good, 5. I have to be face on. There we are. So it's very simple, yeah? But these patients, right? So we had 2 deaths to intracranial bleeding there, 4 deaths to intracranial bleeding there. Now, and so we get the effect of the trial on deaths due to intracranial bleeding. Supposing though, supposing that we got deaths that are not due to intracranial bleeding, and they're going to be the same top and the bottom. So now what's happening is that we've got 1, 2, 3, 4, 5, 6 divided by 1, 2, 3, 4, 5, 6, 7, 8. So there hasn't been any more deaths. You know, the tranexamic acid hasn't caused any more deaths. But we've got these that are due to the trial treatment, and we've just added some of this noise here. Right? Now the ratio is 6 over 8. It's much less, isn't it? It's much closer to 1 now, isn't it? So adding deaths that are not due to the trial, are not affected by the trial treatment, just dilutes the treatment effect towards the null. It's just like, you know, you get a real treatment effect, but it's sort of diluted by the effect, by deaths that have got nothing to do with the trial treatment. So like, you know, tranexamic acid couldn't do anything for the organophosphate poisoning death. You know, it couldn't do anything for the adverse reaction to blood transfusions. So these non-head injury deaths just dilute the treatment effect. And so it's not really the right measure. So the next slide. One of the big concerns in head injury trials is that you save a life and cause disability. So, you know, there was recently a big trial of decompressive craniectomy in the University of Cambridge, where you got these patients with severe brain injury, the brain's expanding in the skull, and so what they do is they do, you know, quite heroic neurosurgery, take the top off so that the brain can expand, and there was much less death, but there was more disability. So we're worried that if we save a life, we'll cause disability in survivors. Well, that's good news. We've got good news there, because look, this is the disability in survivors. The disability is measured on something called the disability rating scale. Very simple scale. Patients treated within 3 hours and beyond 3 hours. The scores are lower in the tranexamic acid group than the placebo group. And a lower score means less disability. So you can't say that tranexamic acid reduces disability. But we didn't really need to say that. It certainly doesn't increase it. So there's no evidence. So we're saving lives with tranexamic acid and not increasing disability. Next slide.
I think Rian, on that part, because we're saving the mild and moderate head injury, so that's why the disability is not too bad.
Yeah,
It's equal on both sides.
yeah, yeah, I think so. This is another measure of disability that when we were planning the trial, we worked with victims organisations, people with, you know, who look after people with head injury or people with head injuries themselves, and we said, what are the things that are important to you? And they said things like, well, fatigue is very important, pain, and, you know, I don't want to be confined to bed. But there's no evidence that tranexamic acid increases any of these things. So, you know, these things are just randomly varying around 1. Next slide.
This one.
Then, everybody's worried about adverse events, right? If we give tranexamic acid to our patients, will we cause heart attacks, strokes, pulmonary embolism, DVT? It doesn't look like it. You know, any vascular occlusive event, 1% in the treated group, 1% in the placebo group. Pulmonary embolism, you know, less than 1%, less than 1%, 18. It doesn't cause vascular occlusive events. Next slide. I think the next slide is the same slide, randomized at any time. So, you know, this is like within 3 hours, beyond 3 hours. This is any time. You know, there's just no evidence there that tranexamic acid is causing vascular occlusive events. So we've randomized now 20,000 in the CRASH-2 trial, 20,000 in the woman trial, and 12,000, nearly 13,000 in the CRASH-3 trial, and we've seen no increase in vascular occlusive events. So if anybody tells you, I don't want to give tranexamic acid because it might cause heart attacks and strokes, they're just wrong, you know. It just doesn't. Any questions on this?
Oh, this is good news.
It's very good news, yeah. So it's sort of getting better as we go along. It's because it goes like, well, okay, there's less death, there's no increase in disability, and there are no side effects, and it's a cheap treatment. That's quite good. Next slide. Now this is the slide. This is one of my favourite slides, right? I think this is the slide that convinces me that tranexamic acid is an effective treatment for brain injury. And it's the effect of tranexamic acid on deaths on the first day. Now, this is the CRASH-2 trial. In the CRASH-2 trial, the only effect of treatment was on the day of injury. There was no effect on day 2, 3, 4, 5, and 6. So tranexamic acid in extracranial injury reduced the risk of bleeding to death. But it reduced the risk of bleeding to death on the day of the injury. After all, we only give an 8-hour treatment, you know. So we give an 8-hour treatment on the day of the injury, and that means on that day, you're much less likely to die. So we got a reduced risk of death from all causes on the day of the injury, a 20% reduction, near enough, a 20% reduction in the risk of death on day 1. This is CRASH-3 underneath. So 0.82 in CRASH-2, 0.81 in CRASH-3. It's exactly the same result. So tranexamic acid, if you give it to a head injury patient, reduces their risk of death on day 1 by 20%. This is high-income countries and low and middle-income countries. Somebody from Australia wrote a really, I didn't like it at all, editorial after CRASH-2 saying, you did CRASH-2 mainly in low and middle-income countries, and those results don't apply to us in high-income countries because we've got, you know, we're so clever and we've got better treatments. I hated it. So So this looks at the effect of the trial treatment by high, middle, and low income. So low and middle income countries, high income countries. Malaysia is a high middle income country, so it's in here, right? So the treatment effect is exactly the same, yeah? So first of all, the treatment effect in the CRASH-2 trial and the CRASH-3 trial are the same. In high income countries, the treatment effect in the CRASH-2 trial and the CRASH-3 trial are the same. In a way, with the CRASH-3 trial, we've been lucky to actually almost repeat the results of the CRASH-2 trial in a slightly different population. But this one makes me, when I see this, I think, wow, the treatment works. It stops you bleeding into your brain on the day of the injury.
Answer this question, right? You're asking on the death on the first day.
Yeah. So, like, you know, no treatment ever prevents death. You know, no treatment stops death. Everybody dies in the end. Yeah? So we only live to die of something else later. You know, unfortunately. It's the reality. You know, you want to die as late as possible, if you can. Right? So, you know, the thing that tranexamic acid does, it stops the patient dying on the day of the injury, but they could die tomorrow or the next day. And you say, so there are these different pathologies killing the patient. On day one, it's intracranial hemorrhage. Give them tranexamic acid, they're less likely to die from intracranial hemorrhage. But on day 2 and day 3, they can still die of brain swelling. On day 4 and day 5, they can still die of sepsis. You know, on day 6 and day 7, they could die of renal failure. But tranexamic acid is not a treatment for everything. You know? It's not a treatment, but on day 1, when bleeding is a problem, it reduces the risk of death. I think it's beautiful. This is just beautiful. I think let's give ourselves a round of applause.